At first, the hospital called it a routine restructuring, a quiet administrative decision buried deep in paperwork and policy language. But months later, internal emails, patient data, and uneasy testimonies would force a question no one expected to ask. What happens when efficiency replaces experience and statistics collide with human care? This is a fictional but realistic documentary-style account of how one German hospital learned that not all replacements are equal. The St. Gerhard Medical Center sat on the outskirts of Munich, a respected regional hospital known for discipline, order, and adherence to protocol. Its corridors were clean, its systems precise, and its leadership proud of German efficiency. Administrators often spoke of optimization, of aligning staff performance with measurable outcomes. For years, the hospital had relied heavily on foreign-trained nurses, particularly from the Philippines. Filipino nurses had become a quiet backbone of St. Gerhard's daily operations. They filled night shifts, handled high-dependency wards, and managed patient overflow with calm consistency. Many had trained both locally and abroad, adapting quickly to German regulations while bringing a style of care that patients noticed, even if leadership rarely acknowledged it. But behind closed doors, pressure was building. A new executive board had taken over, driven by cost modeling and national labor priorities. Reports framed foreign nurses as temporary solutions rather than long-term assets. Internal memos suggested that replacing them with locally trained staff would improve cultural alignment, reduce language friction, and project institutional self-sufficiency. The proposal sounded reasonable on paper. German-trained nurses were readily available, administrators argued, and automation could compensate for experience gaps. A phased replacement plan was approved. Contracts of several Filipino nurses were allowed to expire quietly, with reassurances that patient care will remain unaffected. Within 6 months, nearly 40 Filipino nurses had left St. Gerhard. Some transferred to other hospitals. Others returned home. Their departures were marked by brief handover sessions and polite farewells, but no formal acknowledgement. To management, it was a successful transition. To the wards, it felt like something essential had been removed. The first signs of change were subtle. Call buttons rang longer before being answered. Medication rounds took more time. Patients began asking the same questions repeatedly, unsure who was assigned to them. None of this appeared alarming in isolation. But nurses on night duty began documenting longer handover reports, noting small delays and missed non-critical observations. In the geriatric ward, families noticed changes before statistics did. Elderly patients complained of feeling unattended. One daughter described her father as medically stable but emotionally abandoned. The new nursing staff followed protocols strictly, but interactions felt transactional. Smiles were fewer, conversations shorter. Reassurance became procedural rather than personal. Doctors initially dismissed these concerns. Treatment outcomes, they argued, depended on clinical decisions, not bedside manner. Yet within 3 months, internal audits showed a slight, but consistent increase in post-operative complications. Nothing dramatic, nothing headline-worthy, just enough to raise quiet questions among senior physicians. The intensive care unit told a different story. Veteran doctors noticed that patient monitoring felt less anticipatory. Filipino nurses have been known for spotting subtle changes before alarms sounded. Now, interventions were more reactive. Again, nothing catastrophic, but recovery time stretched. ICU stays lengthened by hours, sometimes days. Administrators responded with more training modules. Workshops on patient communication were scheduled. Checklists were expanded. Efficiency dashboards glowed green, suggesting compliance. But beneath the metrics, the human rhythm of care had shifted. Nurses followed instructions precisely, yet something unquantified was missing. It was a senior anesthesiologist who first requested a deeper review. After 2 decades at St. Gerhard, he had learned to trust patterns more than reports. He submitted a formal inquiry comparing patient recovery data before and after the staffing change. The numbers were adjusted for age, condition, and procedure type. The results unsettled him. Mortality rates had not spiked, but complication frequency had risen across multiple departments. Patient satisfaction scores had declined sharply. Most notably, readmission rates within 30 days had increased, especially among elderly and chronically ill patients. The timeline aligned almost perfectly with the departure of the Filipino nurses. When these findings reached the executive board, the response was cautious. Correlation, they argued, did not prove causation. External factors could explain the shift: seasonal illness, post-pandemic strain. Staffing transitions always carried adjustment periods. Still, they authorized an internal review committee to protect institutional credibility. The committee included administrators, physicians, and one external healthcare quality consultant. Interviews were conducted discreetly. Nurses spoke carefully, aware of professional consequences. Several mentioned workload balance, but others spoke about mentorship gaps. The Filipino nurses, they said, had informally trained younger staff, smoothing crises before they escalated. One junior nurse described learning situational awareness from a Filipino colleague, not from manuals, but from watching how she moved, listened, and anticipated. She noticed patients before charts did, the nurse said. These skills were never written into job descriptions, yet they shaped outcomes daily. Patient testimonials added another layer. Some spoke of nurses who remembered personal details, who calmed fears during night shifts, who noticed pain before it was verbalized. When shown anonymized timelines, reviewers realized many of these accounts came from the period before the staffing change. The committee's draft report avoided emotional language. It spoke of care continuity, experiential competencies, and non-clinical intervention benefits. But the implication was clear. Removing a cohort of experienced nurses had altered patient outcomes in ways efficiency models fail to predict. The final review reached a difficult conclusion. The replacement decision had been technically compliant but strategically flawed. By prioritizing standardization over experiential care, the hospital had underestimated the impact of nursing culture. Care was not only delivered through protocols, but through judgment shaped by years of frontline exposure. The board faced a dilemma. Public acknowledgement risked reputational damage. Silence risked continued decline. After weeks of deliberation, they announced a care optimization review and quietly reopened international recruitment channels, including partnerships with Filipino nursing institutions. The announcement was framed as expansion, not reversal. Yet, internally, department heads understood what it meant. Experience mattered. Cultural competence mattered. The hospital began rehiring foreign-trained nurses, offering mentorship roles and integrating their practices into training curricula. Within months, ward dynamics shifted again. Handover notes shortened. Patient complaints declined. Recovery times stabilized. The data did not surge upward, but it stopped deteriorating. For clinicians, that was proof enough. Some of the returning Filipino nurses declined the offers. Others accepted cautiously. Trust had been damaged. Those who returned were welcomed quietly by colleagues. Their presence felt more than announced. Care rhythms adjusted almost immediately. The hospital never issued a public apology. No press release admitted error. But internal policy documents changed. Staffing models now included experiential retention value as a formal metric, a category that had not existed before. For patients, the change was simpler. They felt listened to again. They felt seen. One elderly patient told a social worker, "The nurses are back." No nationality mentioned, just presence. Healthcare analysts later cited St. Gerhard as an example in closed conferences, never by name. A case study in how human factors resist full quantification. How care at its core is relational. This fictionalized account reflects a broader tension in modern healthcare systems worldwide. As institutions chase efficiency, they often overlook the quiet competencies that sustain outcomes. Skills learned not from textbooks, but from repetition, empathy, and lived experience. Filipino nurses continue to work across the globe, often invisible until absent. Their impact rarely appears in headlines, but it surfaces in recovery charts, patient trust, and late-night stability. St. Gerhard Medical Center returned to its baseline reputation, but internally, the lesson remained. Replacement is not always improvement, and care cannot always be optimized without consequence. In the end, the review was not about nationality or policy. It was about recognition that in hospitals, as in systems everywhere, removing the underestimated often reveals their value too late.